Madam, we are on live.
Good evening, everybody. I welcome you all to this Imaging and Physiology Symposium, our monthly meet. And I thank Dr. Jyotsna for always pushing us, prodding us, and really literally pushing us to excel and perform at the highest level. So I welcome you all to this imaging session because, as you know, imaging is an integral part of coronary intervention. And I would like to introduce our special guest today, Dr. Ankush Gupta, who's been kind enough to join us and who's been, I've been talking with him and is willing to help any of our Wincars members in on the imaging forum. And if anybody has any doubts or to conduct any of the workshops, he's ready. And he has published his original work, that is the OP Cyber LM study, which has been published in the CAT and CVD. And this is the prestigious journal. So he's going to talk about his work in this presentation. I request the chairpersons for this session, Dr. Jyotsna, Dr. Hetan Shah, and Dr. Sarita Rao to take over the proceedings. Thank you.
Thank you, Sujata, for such a nice academic feast of this evening. Can I request the presenter to start the presentation?
Good evening, everyone. Am I audible?
Yes,
Dr. Ankush, you're audible.
Is my screen visible, ma'am?
Yes, it's visible. Can you go to slideshow?
Yeah. So good evening, everyone. Thank you, Dr. Sujata, for giving me this opportunity to present this work. So I'll be sharing with you all one of our original work that we did and we published. And this, study will be an example how, beside optimization of the PCI, what we can learn with the imaging. So let me show you one case. This case, 70-year-old male, he came to us with anstomy. Angiography showed, critical left main bifurcation disease with mid-LAD CTO and dominant RCA. So this mid-LAD CTO was tackled retrogradely with this reverse cut technique. And after that, the left main bifurcation was done using conventional DK crush technique, and that too image guided, that is OCT guided. So we identified it was a fibrotic lesion was modified, and then all the steps of DK crush were followed. These are the steps of DK crush that were followed. I'll not go into detail, but I'll show you pot, repot, final kissing, and this was the final result. So this was a complex left main bifurcation disease with with LAD CTO, mid LAD CTO. Post PCI OCD showed that stent was both left main to LAD and LCX stent was well opposed. Expansion was good. There was no edge dissection, but this patient comes to us after around 9 months with crescendo angina. Angiographic showed that there was side branch ostial restenosis. So when we compared its index OCT, so this was the side branch ostium. This is the side branch L6 ostium that we left large amount of stent studs at the side branch ostium, and this is what happened. So actually, this was one case of one of our trial in which we wanted to identify, how can we improve that, side branch outcome in left main bifurcation angioplasty. As we all know, in distal left main bifurcation disease, PCI is a reasonable, alternative to CABG if you have got a simple bifurcation as per definition. Two trial provisional strategy is the answer. But if you have got a complex bifurcation, you have to go for two stent strategy. And among all the two stent strategies, DK crush has got a maximum evidence in its favor. So we know that all the evidence, they do favor that if you go for a complex bifurcation angioplasty, left main bifurcation angioplasty, the one should go for DK crush. So, but as 1 and 3 year outcome of DK5 trial, that the most common cause of long-term failure or target lesion failure in left main bifurcation angioplasty using DK crush is side branch free stenosis. In view of this, we designed this study to find out whether there are any OCT predictors of side branch free stenosis in left main bifurcation angioplasty using DK crush technique, that is OpCyber left main study. So let me show you what we did in this study. Okay, so in this study, it was a single center retrospective study in which 60 patients with complex left main bifurcation disease were enrolled, and they underwent the left main bifurcation angioplasty using DK crush technique. All cases were done under OCT guidance. All patients were followed up for 1 year, and at the end of 1 year, coronary angiography was done. And the patient with the evidence of angiographic evidence of side branch restenosis were identified, and all these patients, their index OCT were compared with those the patient who never developed side branch free stenosis at the end of 1 year. So let me show you one of side branch restenosis case. So this was a case, complex left main bifurcation disease, underwent left main bifurcation angioplasty using DK crush technique. After final kissing balloon inflation, you can see the angiographic result was good, but this patient came to us with when we did his angiography, there was side branch restenosis. When we analyzed their index OCT, we found that if you see the L mode, there was significant amount of neometallic carina. The CTBP length here was 3.1, but the length of neometallic carina was 2.6. So after final kissing balloon inflation, we left this much amount of stent, iatrogenic side branch, stenosis. Then when we did the 3D reconstruction of the same case, we found that there were a large amount of hanging stent studs across side branch ostium. When we saw the B mode, we found that there is no clear figure of it. That it means that they are near the native carina, there were hanging stent studs. So we can appreciate this hanging stent studs in 3 views: 3D model, B mode, and L mode. So this is another complex left main bifurcation disease, final kissing balloon inflation. Angiographic result was good, but again, this patient had a side branch restenosis. And in this patient also, the CT, when we analyze the L mode of the index case, the CTBP length was 2.3, but the metallic carina that we left, can you appreciate this is a metallic carina found as a red bar, that is malapose and hanging stent studs. It was 1.7, iatrogenic stenosis was 7.73%. And when we did 3D reconstruction, large amount of stent stud. So double kissing crush technique, after final kissing balloon inflation, we left this much amount of stent stud that you can appreciate in 3D view, in a stent only view, and even at, you can see in a B mode, there was again no clear figure of it or a dumbbell sign. So this case, the never developed side branch restenosis, that is NSBR case. And when we analyze these kind of cases, we found that there was hardly any stent stud hanging across the side branch ostium. So the CTBP length here was 2.9, and there was hardly any neometallic carina. When we did the 3D reconstruction, you will appreciate there is almost negligible hanging stent studs across this side branch ostium. You can appreciate that in stent only view also, L mode also, and this is what is known as clear figure of it. Can you appreciate this is known as clear figure of 8 or a dumbbell sign. So let me show you the result of our study. So in this case, study, out of 12 patients developed side branch restenosis. When we did the bivariate analysis of all the cases, we found that in the baseline characteristics, the side branch restenosis group had a significantly higher syntax score as compared to the NSBR group, and we found that significant more number of patients in SBR group had a syntax score of more than 32. And when we compared the pre-PCI OCT characteristics, we found that side branch distal reference diameter was significantly smaller in side branch restenosis group as compared to the NSBR group, and side branch lesion length was significantly longer as compared to NSBR group. When we compared the post-PCI OCT in both the SBR and NSBR group, we found that side branch restenosis group had a significantly smaller side branch stent size, side branch stent expansion, and we also found that all the patients who had a side branch restenosis had an absence of dumbbell sign, had a stent studs hanging on 3D reconstruction, and side branch restenosis group had a significantly longer neometallic membrana as compared to NSPI group, and the iatrogenic side branch restenosis was significantly more in SBR group. And this was the bivariate analysis. When we did the multivariate analysis, we found that side branch distal reference diameter and OCT stent expansion of side branch was the independent predictor of side branch restenosis. And when we did ROC curve analysis to find out the cutoff value, the best cutoff value for the side branch distal reference diameter was less than or equal to 2.8 to predict the side branch restenosis, and the best cutoff value for the side branch stent expansion was less than 89%, again to predict the side branch restenosis. So, as these were two independent predictor of side branch restenosis, we cannot control the side branch distal reference diameter. But yes, we can improve our side branch stent expansion. And when we analyze all these cases, we postulated, or we realized that three things that may have happened that led to such a longer neometallic carina in side branch restenosis. Number one, that we may not have used appropriately sized side branch balloon for a final kissing balloon inflation. Number one. Number two, we may have missed alternate high pressure balloon dilatation. And third thing, that second recrossing after main branch stent placement, we may have gone too proximally during second recross. So we postulated all these three things may have led to longer neometallic carina. So we cannot control our side branch distal reference diameter, but we can improve our side branch stent expansion, and we can also improve our length of neometallic carina. So based on the finding of our study, we have we have designed this modified decay crush to improve the side branch outcome. So after you have divided both the branch, image both the branch, then place your stent in the side branch with 1 to 2 mm pertusion into the left main by keeping another balloon, crushed balloon in the main branch. Then this crushed balloon is as per the distal reference diameter of the main branch. This is the first step shown in the angiography. Then after you have placed your stent in the side branch, always go for first PSO. So why it is required? You always place your side branch stent as per the distal reference diameter, which may be smaller than that of your side branch ostium. So if the length of the stent is small, pull your balloon a bit and do a high pressure dilatation to oppose your stent stud to the carina, or you may use another NC balloon. After you have done a first PSO, you do a first crush. The first crush is by the balloon that is as per the distal reference diameter of the main branch. As you know that this balloon is as per the distal reference diameter of the main branch, and left main is bigger. So your LAD is 3.5 or 3 and your left main is 5. So you know that this part of stent will not be appropriately crushed at this left main. So when you are using a balloon as per the distal reference diameter of your main vessel, your stent will not be appropriately crushed. So you need to take out your pot balloon earlier to crush this stent in the left main. So this is what is shown here. So you take out your pot balloon for doing a second crush or a step crush. When you do this step crush, as is shown in this angiography, your stent is well crushed at left main. It is well opposed here, but the side effect of doing this crushing is that your stent gets deviated away from carina. You can very well appreciate here in this stent boost view. The side branch stent is crushed and it has got deviated away from the carina. So you know that your stent is not there at carina. So whenever you are going for first recross, always go proximally, because your stent may not be there at carina as a side effect of the crushing. So this is the first recross, always. So we recommend that whenever you do a first recross, it should be from the proximal half of your side branch ostium. After you have done proximal recross, before going for final kissing balloon inflation, as your stent is not well opposed to the carina, go for second PSO. Go for high pressure balloon dilatation of the side branch ostium. And when you do this second PSO, can you appreciate from here your stent was not opposed to the carina. Now it's slightly better. So the second PSO is recommended to improve your apposition of the side branch stent to the carina. Once you have done this, second PSO, you have apposed your stent to the carina, then you go for the first kissing. So always go for a second PSO before first kissing. After you have done the first kissing, take out your balloon, place a main branch stent as per the distal reference diameter of the main vessel. Then you do pot. Whenever you are doing pot with a conventional balloon, put your marker at the carina, as one can appreciate here that the pot is being done and this marker of the balloon is at the carina. Once you have done this, now, if you have done all these steps like first PSO, second PSO, and you have opposed your, stent to the carina, now the second recross should be from the distal half of the, side branch ostium. Now, this effort is required. If you go here and if you go here, if you go distally, you will have a lesser length of neometallic carina. So this success of distal recross, for having lesser length of neometallic carina is based on this second PSO. So if you want to have a smaller length of neometallic carina, you should go distally, but you can go distally only when you have done second PSO. Then you go for second kissing, or don't forget to go for a alternate high pressure balloon dilatation before going for second kissing. Then you go for a second pot, and this is the final result. You can appreciate these stent studs, crush stent studs at the left main. We do believe that in this modified DK crush, go for a double kissing, double crush, double PSO, double pot to improve the long-term outcome of side branch. We are doing complex left main bifurcation and we are competing with the CABG. And if we want to give result close to CABG, we need to improve our side branch outcome. And we strongly feel that if we use this modified DK crush, that we are using it for last 1 year, and many of our co-investigators, they are doing it. We feel that you'll have a lesser length of neometallic carina. Always try and go for more than 90% expansion of side branch stent. We strongly feel that it may improve the result of side branch ostium. Thank you very much. We published this article in CCI.
Very nice presentation, Dr. Ankush. And
Thank you, ma'am.
this was a very well recognized publication which you did and well appreciated by everybody. And we all know that side branch restenosis is actually the Achilles heel of left main bifurcation stenting, and an inappropriate results and inappropriate work on it always lands up in the patient coming back to us. The house is now open for questions to Dr. Ankush. Any of the other chairpersons would like to make a comment?
Yeah.
Dr.
Yeah,
Jyotsna,
Ankush.
Dr. Ratan?
Shall I speak? Ankush, it was a really excellent work. I appreciate the new modalities and modifications. It helps in better giving the neocarinal area and less future events. I just would like to know what was the Medina class in your patients, the baseline?
So majority had a complex bifurcation. All had a complex bifurcation, and largely they had a 1-1-1 class.
1-1-1 class. And side branch, you are referring to a circumflex, not the LAD.
Yes. No. Side branch in most of the cases. In fact, out of 60, all the side branch, one was ramus and other was L6.
L6. Okay. So majority is not the LAD as a, because LAD we
No.
can consider as a side branch. Okay. And what about, is there any like distal left main or isolated LAD ostial were there into the, because most of the time the LAD ostial lesions are extended into the distal left main. Okay.
So this study was basically for the complex left main bifurcation disease, in which upfront 2-stent strategy was required, and upfront 2-stent strategy was required, and we did a DK crush. And this was the effort to what was the comparison between the patients who developed side branch restenosis and who didn't develop side branch restenosis. This was actually a deep dive into their imaging characteristics.
Okay. And for
And we found that,
squeezing balloon
side
technique,
branch.
like our strategies, we go for the sequential high pressure in a individual stent and then final casing. The
Yes.
same strategy you applied in your,
Yes.
yeah.
Yes, yes, we all know that sometimes DK crush is slightly lengthy, and
Yes.
it is recommended even in conventional DKC that always go for an alternate high pressure balloon
Yeah.
dilatation before going for final kissing balloon inflation. But we wrote in our article that we may have missed alternate high pressure balloon dilatation that may have led to longer neometallic carina. But these were the three points that we thought that may have led to longer new metallic carina in all the patients who develop side branch restenosis.
Okay. And just last point out, like how precisely you can enter, like first you said cross with the proximal, second is in the, is there any failure rate in this? Or with the imaging guidance, 3D constructions, I agree that you can be very precise. But sometimes like it is a very narrow angles, acute angles, and it is difficult to justify our entry into the stent struts.
So you are absolutely right. We strongly feel that every time you may not be doing able to do imaging after recross. That is why we have recommended that you do two parts of your side branch ostium. First recross from the proximal half of the side branch ostium, and second recross from the distal half of the your ostium. But before that, don't forget to do both the PSOs, so that you may not have opposed your stent to the carina, and we may go abluminally, leading to crushing of the
Yes,
stent and
prior bias and all
appropriate.
things.
Yeah. Yes,
Agree.
yes. But we are
Thank
we
you.
are using this now. If we are doing decay, we are doing using even IVers. We are always checking our crush, because just see, it's not only about doing one left main bifurcation with decay crush. It's about sometimes patients don't want to go for CABG and they come to you for the complex left main bifurcation. We try and assess all of our steps with the imaging, even with the even with the IVers, we always go and check our appropriate crushing of the stent after step crush, and we use each and every imaging like side branch ostial diameter. We do use it. We take out our pot balloon earlier in the case for the step crush, and we really feel that it's not always possible to have a zero metallic carina. No, you will have some metallic carina always, and as you rightly pointed out, it may be angle dependent also. But now we are seeing that we are doing one observation study. We are seeing that our new metallic carina using these modifications, it's much smaller as compared to the conventional decay crush.
And is there in just any in your study, is there any chance of stent deformations after the you found no? Okay, okay,
No.
good, good. Thank you, thank you. Yeah,
Thank you, ma'am.
yeah.
It's a really excellent study. Most of the studies are concentrating on the methodology of the doing, then giving a solutions. But your study is concentrating even on the solution. So that is really then appreciable. And probably after you or before you, I don't know, the Koreans now always do the ostial side branch balloon dilatation to the appropriate size before going to the second stent at all. So they insist on doing that the before. That is an excellent one. So now extrapolating this to the routine provision stunting. So because the restenosis rate, you are saying that the stunt struts are overlapping in the side branch, which is responsible for the restenosis. Even in the provision stunting, nowadays they're saying that again the recrossing and the balloon dilatation, kissing is not required. So do you think that at that stage also we are going to have the same problem? So should we make it as a mandatory that we should do the kissing balloon dilatation even in the provision stunting?
I'm really happy that you asked this question, and Dr. Rupali, she's sitting here. Our next trial that we are doing one RCT and randomized control trial multi-centric, in which we are trying to answer this question that routine kissing balloon inflation in provision strategy, whether it's beneficial and what is the, because till now there is no evidence, there is no randomized control trial, there is no answer to this question for left main provision strategy. And all the studies that have compared routine kissing versus not kissing is non-left main bifurcation, and the results are equivocal. We don't know exactly. So we have, in fact, by now we should have started our enrollment, but I think in a month or 2 month time we'll be starting our enrollment, and it's a multi-centric trial with around 18 centers. And I would request those who are doing left main with image guided guidance, they can be part of our trial. But the only thing is that we are the and hard endpoint is that 1 year angiographic follow-up beside our clinical follow-up. So, but as you rightly said, there is no answer to it that routine kissing balloon inflation should be done or not. EBC, before this consensus, they do recommend that that routine kissing, maybe like in their EBC main trial, they did kissing in most of the provisional cases. But that is mostly based on anecdotal case reports that has shown that if you are leaving stent studs across side branch ostium, they may endothelize. But if I tell you frankly, I don't do kissing at all in provision strategy if there is no significant, not angiographically, physiologically significant, compromise in the side branch. So we look at 5 things, in fact, 3 things. We look at chest pain, ECG changes, TIMI3 flow, and last we look for physiology. And if we are any of them, they are coming positive, like significant, then only go and intervene the side branch for the routine kissing. Otherwise, we don't do. But again, we don't have answer to it. Nobody has got an answer for it. I think in a 2 years time or 2.5 years time, we may have our Indian data on that, because our sample size is really big, around 700 left mains. Me and
Thank you,
Dr.
Ankush.
Rupali, we are trying to do it,
Yeah,
but
Thank
I'm
you.
not
Thank you
sure.
very much, Ankush, for such a detailed description of each and every step. Sarita, can we go ahead for the second presentation?
Absolutely. We'll invite Dr. Rupali to present her talk next. Thank you, Dr. Ankush. Interesting observation study.
Thank you, ma'am. Thank you very much.
Okay, good evening, everyone. So I will just share my screen. Thanks, Ankush. Very nice talk. And I think we have overshoot the time. So I'll just come to my talk. Is my screen visible?
Yes, it's visible.
Okay, ma'am.
Can you go slideshow?
So, yeah. So my talk won't be much about the study, but will be like few cases which we think that when stakes are high, it is IVUS. So this controversy, or this, I would say, the debate will always be the OCT is better or IVUS is better. But we all know that imaging guided PCI, OCT say go for MLD max and IVUS says go for 1, 2, 3. And there have been ample amount of data which can show that these give the scenarios in which you can have a good optimized stent optimization. But there are some scenarios in which I would say IVUS have an upper hand. So what are these 3 scenarios? First and foremost, in CTO intervention, whereas we definitely have no data with OCT, we have good data with CTOs. Second and most important, PCI in high-risk patients of CIN or patient in CKD, in which we want to go for a zero contrast. I don't go for a zero. I always go for a low or ultra low contrast PCI because I want a final shot in which I can document, okay, they have not caused any complication. And third, left main assessment, osteal disease. Again, some people will say we can do with a mother and child catheter, which is again a debatable issue. But I think that a left main assessment should be done if it's IVUS is available, then it should be a preferred modality. So coming over to the CTO intervention, how does IVUS have an upper hand or when the stakes are high? So this was a very good paper which was just published in 2023, which showed that CTO, whenever there is a bifurcation, or either the proximal or the distal cap or in the body, this IVUS comes very handy in these cases. So 3 scenarios. If there is a proximal cap, there is bifurcation, then IVUS helps in localization of the stent's proximal stump. Second, if the side branch is in the body, then the IVUS helps us in tracking the subintimal wire, how it is. And third is suppose the distal cap, then you have to go for a re-entry point in the retrograde approach, or you want to go for a subintimal to intimal, then the IVUS really helps us. So few cases which I have done with CTO with IVUS. So this is a case I think we have showed earlier also, but just for the sake of showing that how IVUS helps. Now this is a 52-year-old gentleman. He presented had the introvulami in 2015 and presented to us in inferior in February 22. And his if you see his angiogram, the left main was normal, L6 was normal, and there was a big ramus-like diagonal, or you can say diagonal, which was coming in the proximal part, and post-diagonal, the LED was total occluded. So the stem was not visualized. We don't know where the LED was occluded. And if we see the RCA was having a mid-severe disease, and it was retrogradely clearly see it was filling the LED. So we know that LED was occluded 5 years back. It's a CTO, and we RCA is the recent event which happened. And we can clearly see there was a bifurcation at the distal cap. So what are the problem which we, in this case, if we want to address this LED, we know that the LED ostia, the proximal stump is ambiguous. So we don't know from where to we have to puncture this case. There was a large diagonal which was present there, and there was a bifurcation at the distal cap. So we don't know that where will our wire will enter. So what are the options which were available if the proximal cap ambiguity is there? Either we can do an IVUS guided puncture, either we can move the cap, or we can go a retrograde. Since this was a big branch, we proceeded ahead with IVUS guided proximal stump localization and followed by a live IVUS firing in this case. So 2 axes was taken to see the contralateral injection, and it was a 7 French EBU guiding catheter. And if we see, then we parked the IVUS catheter in the LED in the diagonal, and when we took the pull back, how to identify the stump? Whenever the stump comes, there are 2 things which we have to look for it. One, there is a 3-layer structure which gets visible, and suddenly the diameter of the artery becomes bigger. So if you see at this juncture, at 6 or 7 o'clock, we can see a stump-like structure coming, and suddenly the artery becomes very big, which was earlier 2.5, it became a 3.5. That means we have entered the crossed the proximal stump. So we localized the stump. We took a fine cross microcatheter, placed our fine cross microcatheter. This was the stump, if you can see, at 6 o'clock to 7 o'clock position. And this was the wire. I wanted to puncture this stump so that my wire goes into intimal part. It doesn't go subintimal. So you can clearly see my wire tip. So IVUS is already present there at the diagonal, and my wire is moving. So this wire is, when it is moving, you can clearly see that when I'm redirecting my wires towards the stump, it should go into the intimal part. So this was a Conquest Pro 9, which was taken. And this Conquest Pro 9, when it punctured it, you can clearly see it is entering the stump part in the mid part of it, and which we confirm. This is as a snapshot which was there, wire at 11, 10, 8 or 9 o'clock position. And this was the wire penetration, in which we can clearly see that wire is entering the intimal part, that means in the stump. So this was confirmed also angiographically. We really don't know whether we are in the true lumen, but the IVUS was very sure that we entered to the true lumen, and it was the wire was advanced under the contralateral injection. And after the contralateral injection, we just changed the wire into regular workhorse wire, and we deployed a stent in a provisional manner without touching the diagonal, because diagonal didn't show any significant disease. So how does IVUS help in this? It was a complex case of a proximal ambiguity, and my stakes were very high risk for going for a subintimal wire problem, because we were not able to localize the stump. So the stakes are high, but the IVUS make the case, which was very difficult and an easy task, and we completed the case within 30 to 45 minutes. So there are different steps, which I will not go into detail. You have to put a floppy wire, you have to go for a diagonal pullback, and from there you have to localize the stump, and you go for a puncture of the stump. It is sometimes not always useful, because if there is a calcium present at the proximal stump part, we can't see beyond the calcium, so the stump cannot be visualized. So becomes difficult in case of side of occlusions. Second scenario, whenever the subintimal wire position, the IVUS becomes sometimes very handy if you are able to cross the IVUS. We don't have an anti-all IVUS in which you go for an anti-grid looking, but there's a case which was published, which was showed that if you have an anti-all wire IVUS, we can clearly see that if the wire is subintimal, and we can redirect the wire from the subintimal to the intimal part, which I think we cannot do it with your OCT. And this thing in which we have going from a subintimal to intimal can decrease the chances of your subintimal tract injury in these cases. Second and third most important, this was a case which was done. We can clearly see, if we want to see that whether our wire or this intimal or in the false lumen or true lumen, the true lumen was always shaped as a kidney shape. If you can see, this was a done which by one of my in our center, which showed that the IVUS is in the subintimal part and our true lumen is a kidney shape which is just compressed there. So that means if you deploy a stent in this area, it will be all subintimal. So we have to be very careful. If we find out that this is a subintimal entry, we have to redirect the wire, if possible, into the entry into the true lumen part. Otherwise, we will land up into a challenging situation. So beyond CTO, what is the second most important scenario in which my IVUS would be really helpful? This is a PCI in patients, especially with CKD or in higher risk cases for CIN. We all know that IVUS reduces the contrast use. This was a study which was published in 2014, which clearly showed when if you go for angio-guided versus IVUS guided, there was definitely reduction of contrast by at least 19%. So we know different definition, what is low contrast PCI, ultra low or absolute zero contrast PCI, depending on the operator feasibility, they can go ahead with it. But I usually go for ultra low or low contrast PCI rather than a zero contrast PCI. And there are different tips and tricks which have been advised to going for these low contrast PCIs. But in these cases, what are the challenges? Usually when these patients are CKD, they have a very heavily calcified lesion or a diffuse lesions. And we all know whenever we do imaging in these cases, they always have a better outcome, especially in calcified lesions, to see the stent expansion, and especially the plaque modification. So IVUS guided lesion assessment and strategy plays a very important role going for ultra low contrast PCI. So this was, how can you do it? Either can be a coronary marking technique or a stent enhancement technique. And IVUS co-registrations are there, but I will show you a case in a poor man's IVUS co-registration. When you don't have a co-registration ACR machine in your lab, still you can go ahead with your co-registration. So this is an example of a 72-year-old gentleman. He presented to us with angiovolemi, and he was having a creatinine of 2.1 with an eGFR of 27. We all knew that his Meheran score was 16 points and he was developing 57% risk of developing CI in this case. So we have to be very careful in this case going for a PCI. Since he having a post-MI angina, we wanted to do an angio in this case. If we can clearly see, this patient had a normal left main, LAD ostia was having some doubt, was a disease, followed by a mid-severe disease in the LAD part. And if his RCA was seen, RCA was also a diffuse disease starting from the ostial part of the RCA leading up to the mid-RCA. Now, the challenges, since he presented with recent angiovolemi, we wanted to fix his LAD because he was having recurrent rest angina. So, planned, we go for IVUS guided assessment to assess the LAD ostia. And if we want to ostial disease, we have to do it from ostial stenting. Should we go from a left main to LAD stent? In this case, I didn't want to go for because RCA was already diseased. And if by chance any plaque shift or coronal shift causes my ramus or LCS get pinched, the patient will be again into catastrophe. So without giving any contrast, we place the screen as a roadmap, wired both the LAD and the ramus, dilated the critical most part in IVUS. So from IVUS, we definitely can see there was some fibrocalcific lesion. That means we need some cutting balloon or a NC balloon in this case. And when we came, this was a concentric calcium which was present in the LAD ostia. And as we came proximally, the LAD ostia was having a mild plaquing, but the carina was okay in this case. So there were some screenshots I will show you in the next slide. So this was now what I was telling about the poor man's co-registration. Whenever you get a thing on the IVUS, just take a cine or a store as a mark that this is my distal landing zone. Then don't move the machine. So this was the distal landing zone, which I marked on the IVUS. This was the mid, which was the narrowest part, fibrocalcific. This was the LAD ostia, which I was seeing. And this was the distal left main, which showed that there is no significant plaquing in this case. There was some calcium. So I didn't want to, that means I was safe. I don't have to come to the left main. I will try to place just at the LAD ostia. How to mark the LAD ostia? I took two views, one as arrowcranial and another as apicaudal and iliacaudal, to mark my IVUS where the L6 just got entering into that part of IVUS. So after this no contrast till now. The stent position in the two marking views, which was LED ostial stent, which was shown by IVUS, which I marked on the angiography, a small puff of 2 cc contrast because I just wanted to be careful, and the stent was deployed. This was done after cutting balloon because there was a calcified lesion. And post stent, there was some under expansion, which I dilated with the NC, and I got a good distal left stent expansion in this case. So I always take a 2 final shot because maybe to look for just for perforation or dissection, which I have created. And this was the final shot which I took. So total contrast volume in PCI was only 10 ml. Post 48 hours of the creatinine was 1.9. Patient was discharged after 72 hours. And 6 months follow-up, patient is doing fine. So there was no CIN which I caused by due to PCI. Third thing, sometimes you have a compromised distal flow, blood flow, there is no clearance. I think then IVUS has a little upper hand over OCT. Whenever you see this type of a lesion in which there is a calcified nodule or a thrombus, then this may be possible that you can go for an IVUS in these cases because you won't have a good blood clearance. So in conclusion, if you ask me, what are the 3 stakes in which you have a IVUS helps us, especially of IVUS in CTO, we all know their role is multifactorial. Whenever there is a proximal stump ambiguity, then always localization IVUS helps in handy. For the wire confirmation, intimal or subintimal, or our catheter or IVUS is in the false lumen, it comes helpful. Stent expansion, we all know that is always better in CTO vessels because we all know the CTO vessels are always hypoplastic, and because when they are open up, then they grow up. So this imaging is always important going for a CTO interventions. Revascularization in CKD patients, we all know there's a high risk of CIN and should be always done ischemia driven and imaging guided so that have a minimal contrast in these cases. And PCI can be performed without or ultra low contrast with the imaging. And left main assessment for me, I think osteal lesions, I think IVUS has a better role than OCT. And these are the 3 scenarios in which IVUS helps us use your high stake conditions. Thank you.
Thank you, Dr. Rupali. That was a very excellent presentation. I think the most important thing which every interventionist now has to realize, and which I think people have generally accepted, is that imaging helps us in every way possible. Now, which modality to use is a lot of times operator's choice, and is a lot of time dependent on the lesion and the kind of intervention you're doing at that time. But most of the labs in India have one or the other modality. And there are very few centers which have both the modalities available. I'm lucky enough to have them. Most of the institutes have it. But most of the operators in labs across India have one or the other modality. And what is also very important to note is that there are ways to do everything with the imaging modality that you have. For example, the ultra low contrast PCI can also be done with OCT if you're using a saline OCT in a CKD patient. And if you're doing an osteal left main lesion, you can use the telescope because the proximal tip of it is infrared compatible. So there are ways to use both the modalities according to the situation and the type of intervention that you're doing. But I agree that imaging makes our life so much easier, so much more upfront planning becomes easier. The end results become so much better, and the patient definitely fares much better. So great presentation, Dr. Rupali. The house is now open for expert comments and questions. Dr. Jyotsna and Dr. Hetan.
Yeah, excellent, Rupali. Really, the IVUS is outstands sometimes with an OCT. I agree for that. If the chance is given, every complex case I want to start with an IVUS, I may require a OCT for the final to have then a good result. So that I'll accept it. So many of the time, the IVUS is really going to be the helpful. Thank you.
Thanks. My only thing is like what you said in CKD patient, like sometimes, I don't know, Ankush is there, he has done a very good study for saline OCTs. But my only worry is, for OCT, for get a good clearance, you have to give 4 runs, 5 runs sometimes. And I don't want to give a volume overload also in these because these patients are at a very brim of your volume preservation, because their LVDP is on the little higher side. A little extra of 50 or 100 ml volume also, sometimes it may cause some deterioration in these patients. So I think in these cases, if your LVDP is okay and the patient is not anuric, then these cases can be performed with saline OCT. But if he's anuric and he's on dialysis dependent, then I think it's better to go for IVUS in these cases. Rather than going for a saline OCT, like my personal, because in our institute, we go for it. It's better to, like recently, last week, we did one PCI, I was guided. I just gave 20 ml, but still the patient was anuric. He was a CKD dialysis dependent patient. He developed LVF, because these are very grim situations in these cases, which I think IVUS may be helpful
correct,
in these.
Dr. Rupali, given a choice, I think most of the operators in a CKD patient, if they have IVUS and OCT both available, would upfront choose the IVUS. Also because when you take the pullback with the IVUS, generally the patient remains very stable. And whenever you give forceful injections using the OCT, then many a times there are problems, especially if you have a vulnerable lesion at that point. Many a times when you give repeated forceful injection, the patient crashes also. But the results with the newer Obstar catheter are much better. Usually you get with one shot, you get the results, and it's much more trackable also. So the older OCT catheters were not so patient friendly. The newer catheters are much more patient friendly. So, but I think again, upfront, if an interventionist has both in their lab, they're going in for a CKD patient, they would choose IVUS. But your lab has one modality and you have to do, and most of the labs are one or the other, then I would say that, both are possible. Both can be done. Especially many a times when, these CKD patients have huge amount of calcifications also. An upfront planning of the case is very important. And with the IVUS, we have limitations about how much we can assess the calcification. We're not able to see really the depth. And the river bifurcations, which we see, are sometimes very misleading many a time. So in that, OCT really helps us to score. And again, when we're doing left main, again, seeing the struts across the ostial circumflex, so much more clearer on the OCT when you're doing a distal left main bifurcation. So I think each imaging modality has its beauty, has its fallbacks, and the operator has to get comfortable with both and learn to manage with both, whichever situation. Of course, the luxury of having both with us is the best thing that could happen.
Correct, ma'am.
I think we'll go to session 2. Yeah.
Absolutely.
Thank you, ma'am. Thanks for the opportunity.
So the session, I invite the chairpersons, Dr. Tripti, Dr. Kavita, and Dr. Cecily, and Dr. Shiva, Priya, and Ritu are here to discuss. So I'll be presenting. Actually, I wanted to present a case, but my case, did not turn up or did not agree. So I have a series of few cases which I will be showing. So my topic for today is, sorry. So can you see my screen?
Yes, ma'am, we can.
Yes.
Yeah. So my thing is left main intervention is intravascular imaging mandatory. So that's what I am talking about. So, that pre-PCI, IVUS, you look at certain things. You look at the plaque composition. You look at the osteal disease, circumflex disease. You can decide upon the stent size, length, port balloon. So in a post IVUS, what we have to do. You look for under expansion, incomplete lesion coverage, any malapposition, deformation, or any complications. So what are the situations why as a OCT has helped me? So we did a stenting of the mid LAD and the catheter was damping. And this is the LAD lesion. At this point, we were not sure whether the LAD was, whether the left main was diseased or not. So this is a constant situation which all of us face. We have a damping of the catheter. We don't know whether the left main is significant. It needs to be stented or it needs to be left alone. And in such situations, what I did was I just put an IVUS catheter in, and then I look at the MLAs, and you can see that the MLAs are good, and the plaque distribution, there is only some plaque, and there was no significant stenosis of the left main, and then we left the patient. Then I had a 62-year-old male, diabetic, hypertensive, NSTEMI, severe LV dysfunction. Patient underwent multiple plastic surgeries for the left lower limb. He had left main and triple vessel disease. He was not willing for surgery. So you can see that there is osteal occlusion. You can see that there is a disease in the shaft of the left main. You can see that there is a diagonal disease and LAD disease. And you can see that there is right coronary disease. So first we fixed the right coronary lesion. We finished the right coronary angioplasty. And now what is the plan? So we thought maybe we could just do the shaft of the left main and end the step without entering into a bifurcation mode. But then we did the IVUS, and you can see IVUS is showing a fibrofatty plaque. And as we come proximally, you can see that the LAD is very diffusely diseased. And as we come to proximally, this is the confluence, and you can see that the LAD ostium just beyond the confluence is diseased, and this is the confluence of the left main. And as you come proximally, you can see the left main is diseased. So basically, there is no landing zone. And then we decided that there was not much of calcification, and it could be as you come proximally, you can see that the left main is diseased, and there is this is the shaft involvement. And as you come ostially, it's a very huge left main, as you can see. So at this point of time, this is the analysis. You can see the still frames. You can see that even at the this is at the diagonal ostium, and you can see that there is some calcification, but we thought that preparation is enough, and we don't need any deeper tools. And as we come ostially, you can see that there was landing zone, as I had shown. The confluence, there is LAD ostial disease, and distal left main, there is disease, and this is the left main. So at this point of time, so we decided to stent from the left main to LAD. But before that, we did the sirolimus DCB we opened the occlusion, we put a sirolimus DCB because we have so much stents and we wanted to reduce the stent burden. And at this point of time, we also did a sirolimus DCB to the diagonal. And this is the post-diagonal result. And because, as I said, we wanted to do reduce the stent burden. And at this point of time, we prepare the lesion because preparation is the key. We did the cutting balloon 3.510. We did a 3.548 expedition stent, and we did a pot 5.8. And these are the post results, the MSAs, which are more than 6. In the LAD 6.2, 6.8. And as you come to the ostium, according to the new criteria, it should be more than 8. And you can see the 9.1, 13. So these are the, and this is again, I come into the left main, I recheck because this is with IVUS, you can go in again and check, and you can see that I got very good MSAs, and the ostium of the left main is covered. And with these IVUS, we did not do any kissing balloon, or because we concentrated on the left main and getting a good MSAs. So then I had a 41-year-old male, no coronary risk factors, inferior STEMI. He underwent, you can see our patients are younger. He underwent a primary PCI with DES to RCA, and then you get stuck. You see that there is an left main disease, and there is some plaque in the OM1, and this is a small circumflex which is diseased. So at this point of time, you're stuck, and you have to do the left main stenting. So we did the OCT at this stage. You can see that it is a fibrous plaque. And as you come proximally into the left main, you have a very high risk plaque. That is, a lipid content is very high. You can see the plaque and there are macrophages and this is as you come proximally, you can see that the left main plaque is there's a lot of lipid inside the plaque, and this is as we come proximally, and the left main is normal. So this is the situation. So at this point of time, we did an analysis. Distally, it is around 3.5 EL to EL. And you can see, as I said, the high risk plaque, the macrophages. And as we come proximally into the left main, you can see the lipid plaque, you can see the confluence of the LAD and confluence of the left main. And as you come proximally, and you can see the huge left main proximally, it was this is a 4.4, but as we luminal area, but we came proximally, it was more than 4.55. So at this point of time, because of the thing, we decided to prepare with an angioscope. Then we did a science expedition, and this is the post end. You can see that there is not much plaque shift. And then we did a pot. We chose the 5/8 pot. Then we did a distal dot, which is with a 3 point with a 412. We did a dot, and then this is the result of the left main. And as I said, as Dr. Ankush was also saying, that we did not do any kissing balloon of this patient. We kept it simple. So at this point of time, we took the MSAs. The MSA is the most important marker of most important for the future MACE. And the MSAs were very good. And as you can see, there was no stent malapposition or under expansion. I will show the still frames, and this is the left main stent. And we did, as Dr. Ankush was pointing out, we on the 3D thing, we look at if there are any struts, many struts which are hanging across the circumflex ostium. At that point of time, if there are struts and we feel the necessity is there, then we are doing kissing. Otherwise, we are not doing kissing. So this, as I said, we try to get good MSAs. The MSAs is the most important marker of future MACE. So 7, 8.4, you can see in the left main, 12, and the LAD ostium also. We got very good MSAs because now the criteria are much less liberal, that is 9, 10. These are the areas which we got. So this patient was a pharma company. So he comes back after 1.5 months for a check shoot, and you can see that if we get good MSAs and if we do a proper pot and proper imaging to guide our left main intervention, because we are competing with the Lima, you can see that there is no evidence of any restenosis. So this was about 20 months later. So coming to what is the left main disease in imaging trials, you can see that even complex trials like October, Renovate Complex, the left main is very less. The left main disease in imaging trials is only 19% highest in the October because it was a bifurcation, and Ultimate did not report left main separately. It said left main or LAD is 56%. And what is the use of IVI in the contemporary trials of left main? Excel and Nobel, there was 77 and 72%. But if you take the recent EBC main or the DK crush, it's abominably low, like they're just 40%. But what is the evidence for use of intravascular imaging? Do we have any randomized trials? No. There is an observational data, that is the left main compare trial, which shows that at 10 years, the 46% reduction in death and 43% reduction in MACE with no change. And the largest database is the British Cardiovascular Society Intervention Registry, 11,000 patients, and there is a 43% reduction with IVI. What is the randomized trials? October trial, only 19% are left main, and OCT guidance reduced MACE. So we have an upcoming trial, which is a randomized trial of intravascular imaging in left main, and that is the optimal trial. So we know that IVUS guided intervention. IVAS has got more data than OCT, and OCT is coming a close second. So you can see that all events like cardiovascular mortality, all-cause mortality, myocardial infarction, stent thrombosis, target vessel revascularization are all better with the IVL guided. And you see that there is a graded benefit of the MSA in the left main. As you get higher and higher areas, that is 11 to 17.8, that's what we are trying to achieve. And you see that the event rates are lower when you in the largest tertile group. This is the Excel sub-study. So basically, this was what in the DK Crush study, and this was published by Kim et al. And they have the old CAN criteria 5, 6, 7, 8 is no longer accepted, and we need almost 5.7, that is 6 in the left main. LAD ostium, look at it, 8.3 and 11.8 in the left main. And look at the rates at which these are achieved. This about 55% have an LAD MSA less than 8.3 and MSA less than 11.8, about 65%. If you have this LAD MSA less than 8.3 and L6 MSA less than 5.7, look at the MACE. It is 5 times higher, 5.5 times higher than if you achieve these areas. So most of the thing, it is not the technique. We have to concentrate on what MSA we are achieving. And we have to follow certain protocols. And if we achieve those protocols, that is at least more than 90% distal reference or 80% if funnel shaped. And in such situations, these are for ostial and shaft left main. And if you take distal, if it is a provisional stenting, 2 stent techniques, this is a very interesting article by Jose, who does a lot of left mains in neurointervention. And they found that if you follow a protocol, the event rates are the least as to when you do not follow. So just doing IVAS is not enough. We have to follow certain protocols. We have to follow, achieve certain MSAs, and maybe in the future, my take is maybe we look at the ostium of the circumflex if we are doing a distal left main bifurcation. And if there are no stent struts across, we don't do anything. And if there are no stents, if there are stent struts, we try to push them and then do a kissing and then try to achieve good results. So this is the OCT October trial, and which has shown that in a randomized study and in best of European centers, look at the unintended stent deformation is 9.3%. And the highest is almost 1 in 5 left mains will have a stent deformation. And look at the major adverse cardiac events. If that is left untreated, the major adverse cardiac events are so high. So how do you find these? Unless we do imaging, we will not be able to see abluminal wiring or stent distortions. So in conclusion, stent distortion of 20% is very, very important in the left main. And mortality reduction, it's not only MACE reduction, but mortality reduction is robust and mandates the use of intravascular imaging, and standardization of imaging in the left main is mandatory. Thank you.
Excellent, Sujata. That was very, very nicely explained and given all the, guidelines and how much area we should achieve. It's really amazing. You have done wonderful cases and explained so well. Only one small question. You have done nicely DCB in the distal LAD with the proximal stent optimization. After the DCB, we are missing some physiology here for the post stent physiology, we call it. So maybe sometimes when we do DCBs, of course, you have done proximal optimization with pre-dilatation with DCB, but I would like to get some amount of sometimes we should do physiology based, like either pressure wire or FFR.
Yes, actually, I did the physiology in the diagonal. I've been thinking, that means I have to put the wires before, and So then putting the wire before, it's so expensive. So maybe I'm thinking in my mind whether I should get angiography guided
Yes, right.
UFR, or maybe I should acquire it so that in future I'll do all my DCBs with angiographic FR and then maybe
Exactly.
do the DCB.
That is
make
recommended.
sense. That is in my thought process. Okay.
Excellent. Yeah.
Yeah, thoroughly agreed. Excellent cases, Sujata ma'am. We really enjoyed listening to you. And I think the point that you have made is very relevant, that it's not just doing an IVUS, but having a protocol by which we need to follow our IVUS in our patients, which makes it all the very important. I really enjoyed seeing your case in which the patient had inferior wall MI and a primary PCI was done, and how the left main was, addressed. So was it in the same setting, ma'am?
No. This was in another sitting. Primary PCI, we don't do any left main. We did a left main to LAD in an anterior MI, circumflex ostium is pinched, but still we don't do anything. It's flowing, leave it, come back. Left main just, MI, just come off the table as quickly and then decide.
Yeah. So excellent cases, and the point is very well taken, that it's not just the imaging, but the protocols behind the imaging which would actually, make the difference.
Yes, I strongly say we have to achieve the MSAs, whatever, with preparation. Previously, we used to do a lot of direct stenting and all that. Nowadays, we prepare a lot, cuttings, angioscalps, IVLs, atherectomy devices. And then it is like DCP, you're just putting the stent, that's all, right? Nobody wants to ask a question.
No.
You left everyone
You have made it clear. You have made it so clear that we really don't have questions regarding left main and trial, October trial. You have discussed nicely. You have covered everything. And I think in interest of time, should we move to session 3?
Yeah, we'll move to the session 3 and you have to take over the session 3. You are the moderator for this session and you have Anupam Goel, Banu and Dr. Banu Dugal and Dr. Veena Nanjappa to do this session. And first, Richa Gupta wants to present Dr. Annapurna. I'm sorry, but Dr. Richa has some work. Can we ask Richa to present first?
Yes, no problem. No problem.
Okay, Richa, you can start.
Yeah. Thank you, ma'am. Good evening, everyone. And I'll be sharing my screen.
It's your call day?
No, ma'am.
Okay.
Okay. Is it visible? Yeah. The slides are visible?
Yeah. Please go ahead.
The topic is instant restenosis CTO, type 4 CTO, where wire crossing is not the only hurdle. And we will see how this case posed a difficulty to us. This patient was a 65-year diabetic female who presented with rest angina since 3 to 4 months on and off. And she was a follow-up case of inferior wall MI for which her RCA was stented in 2022. 2 discs were implanted, 2.75 and 3.0. She was taken up for angiogram and it showed a double vessel disease. Her RCA stent was 100% occluded. Mid LAD was showing a 90% disease. Her echo was suggestive of an EF of 45% with inferior wall mildly hyperkinetic. So now she was taken on. Earlier, we knew that her LAD was also diseased, and when she came, we thought this might be because of this pain is because of LAD, and we thought of treating the LAD. But actually, this was the angiogram, and it showed that RCA was CTO, so we were bound to treat RCA first, followed by LAD. So JR was taken, femoral arterial access was taken, and I just took a feeler XT wire. The wire was crossed, and it was confirmed from the left shot from the LAD, and the wire was in true lumen. Now, after this, I tried to cross with a 1.5 mm balloon, but this balloon couldn't cross beyond this distal C of the vessel. Even the smallest of the balloon, we had Nick Nano with us also. I tried to pass that also, but that also didn't cross. So now next step was how to tackle this particular lesion. I had two concerns, that whether my wire has gone behind the stent struts, that's why the balloon is not going, or any other biological reason for this, mechanical or biological reason that the balloon was not going. So now I thought of taking guide liner. So there are different steps to go ahead with the balloon uncrossable lesions. Either go with a small balloon wedge technique or balloon assisted micro dissection. We can increase our support by guide catheter, guide extension wires, so taking a wire in a side branch or an anchor balloon or anchor wire techniques. Then we have finally, if nothing works, we have atherectomy or laser that we can do. So rotablation was later into my mind. I first thought that I'll take a guide catheter and try to pass my balloon with that. Even with this guide catheter was not going beyond, because it was a very tight lesion after the proximal RCA itself. So I used this inchworm technique by inflating this 2 mm balloon, just glided the guide extension catheter over it. And it could come finally to this point where that 1.5 balloon was coming. So after spending some time over here at this very point, trying to inflate, deflate the balloon and glide the guide catheter over it, I tried to move it a bit forward, and we can see that the guide extension could be moved till a little bit forward. And after dilating the 2O balloon here, it gave way to my balloon and it could cross thereafter. And we can see that in this last view, it could suddenly cross that particular distal lesion. So sequential dilatation was done with the balloons, and this was the flow. This is not working well. I had to see that what was the reason for this non-passage of the guide extension catheter and the small balloons. And in the OCT, I could see that my wire was always in the true lumen. It was never passed beyond the lesion. And there was this neointimal hyperplasia with lipidic plaque as well. And here we can see the development of this was the area where I had a calcium nodule, because of which nothing was getting inside the lumen, except for the wire. There was so much of difficulty. This was a calcium nodule, which was, this showed it beautifully. This particular calcium nodule extended almost up till 4-5 millimeters. And thereafter, we had both neointimal hyperplasia as well as neoatherosclerosis in this patient. So this was the neointimal hyperplasia at this area. Then this was the calcium nodule, which we could see. And so the mechanism of ISR in this case was all non-eruptive calcific nodule, neointimal hyperplasia, and 2 layers of stent in mid-RCA. It was a mixed etiology, including both mechanical, under expansion at calcification site, and biological factors, that is NIH and calcific nodule. So after this, I dilated the lesion with a 3O10 Wolverine cutting balloon at 12 to 16 atmospheres, specifically at this particular site of calcification. And thereafter, I didn't want to put in these stents, because already we had 2 layers. And if I would have put another stent, that would have been 3 layers, specifically at that point. So just 2 DCD of 2.75 and 3O were inflated for 90 seconds each. And this was the final result which was achieved. So we know that the prevalence of complete occlusive ISR, it represents almost about 5 to 10% of all CTO lesions. And issue and intervention of ISR CTO, it includes a large plaque burden, and there'll be at least 2 stent layers leading to a higher stent recoil, further increasing ISR and thrombotic risk. And the defining problem is the passage of ISR CTO with a wire. You can always go behind the strut, and once you dilate it, either you increase your subintimal space if you go into the subintima. If you are behind the strut, you can crush these stent struts which were previously deployed also. So that is the risk of deviation of wire towards vessel border, which then may slip through the strut and pass outside of that. So even if the wire re-enters, such a situation needs to be recognized before a balloon is advanced in order to avoid deformation of original stent. In my case, it was difficult. I didn't have IVUS that day, so OCT imaging I needed to do it to see whether the wire was in true lumen. So I had to first dilate it with a balloon. Careful assessment of wire within the stent from bilateral views is another way where we can see that if we are outside or inside the stent. If a balloon is then following the wire but gets stuck within the stent, this might hint at a wire passage through the strut. So other technical issues are guide backup and then balloon uncrossable lesion, which we quite commonly encounter. So guide extension is a bailout in such cases, and the other option that we have usually is rotor ablation. So guide extension, it reduces friction for the entry of hardwares, it improves the guide support as well. The next issue that comes with these ISR is to understand the causative mechanism of ISR and thus deciding the treatment strategy. Mehran classification, it doesn't discuss about the causative mechanism. So thus Waxman instant restenosis classification comes. And imaging is, of course, important in the way to elucidate the mechanisms. I'll not go into these details, just this slide, that there can be mechanical factors, which include stent undersizing, stent underexpansion, vessel calcification, stent fracture, and geographic miss. And then we have the biological mechanism, which is neointimal hyperplasia and neoatherosclerosis. Neoatherosclerosis is, we all know, it is characterized by either lipid-laden plaque or by the presence of neocalcinosis. Attenuation we can always see with the lipid-laden. So these are the factors which shows that it is a neoatherosclerosis. So this is just a table which shows us Waxman instant restenosis classification. We had this type 4 in our case, which was total occlusion. And this is a chart, elaborate chart actually, which tells us about the therapy which we should be using. So in type 1 mechanical, if it is a stent fracture, clear-cut DES has to be implanted in that case. If it is under expansion, we can go with a high-pressure NC balloon, cutting balloon, followed by DCB, or if the underlying cause is the presence of calcium and all, then rotablation IVR followed by DCB can be done. Then type 2 biologic, in NIH, we can expand the stent with the use of scoring balloon or a cutting balloon followed by a DES or brachytherapy, which we don't use it here. And then if it is a neoatherosclerosis without calcification or with calcification, now the guidelines suggest that we can use DCB in all of that. If it is a mixed etiology, again, individualized treatment has to be done. If it is CTO, then DCB, DES, or brachytherapy can be given. And type 5, there are 2 layers of DES ISR, either PCI or CABG, because we never want multiple layers of stents in the vessel, because they ultimately will lead to the risk of development of ISRs and thrombosis. So there might be arguments against the use of DES in long-stented diffuse ISR. And ISR C2 is the worst case scenario. So my take on this, and the studies also have shown that an additional layer of metal together with anti-proliferative activity may impair subsequent reendothelialization and thus render the treated lesions susceptible to future target lesion revascularization or target vessel failure. And several layers of metal may trigger stent strut fractures as a possible cause of recurrent ISR. So the concept of delivering the required anti-proliferative agent can be through a drug-eluting balloon without implanting any other metallic layer. And this was shown in the PEPCAT-2 trial as well, which showed quite good results. So this ultimately, you have to define the ISR lesion, identify contributory factors, address the mechanical issues, and treat as per underlying stent type. Thank you.
Nice case, Richa, and you have explained how if you have crossed the wire nicely and you have checked through contralateral injection that you are in the true lumen. So most of us are stuck there, that how to get through. So you have either two things: you increase the support, or till the place your microcatheter goes, from there you can exchange to rotawire. Sometimes we have to go for that strategy. And regarding your long ISRs, when you are creating a metal jacket, it has also been seen when the distals, if you are making a stent jacket and the distal vessel is too small, that is also a precursor of having an occlusion of the stent, of that stent. So I would invite other chairpersons or panelists to comment, and if they want to share anything regarding. Nice case, Richa, nicely managed.
Excellent, Richa. You did very well. there was so much long nodules. I was thinking all the while, probably next step you would take either orbital or rota, because that kind of, chunks of nodules, and you have demonstrated it so well in your OCT pictures and length of the. I was thinking maybe you will go next for the orbital or rota. I don't know exactly speaking what modality would be the best, but in my consensus, I would think about these two modalities would be the better choice for shaving out the, those
Absolutely, ma'am.
chunks
Actually, this
and
case I was doing in the evening around 6 o'clock, and I didn't. This was a RPMJ patient, Ayushman. So at that point of time, while even taking the balloon past beyond that lesion, it took me almost 1.5 hours. I didn't have rota on table. IV was one therapy. On the hindsight, I was thinking that now my balloon has crossed and cutting balloon IVL, maybe I could have done it. But at that time, this I did in 2023. Nothing was there, and it was evening. I couldn't. I was committed to do this case because already so much of dissections and everything happened. So I had to do. I just that's why I didn't implant
no,
stent.
excellent. You have done very well, and you have got good expansion, the full dilatation, everything you have pre-dilated and post and did the DCB very nicely. So there is nothing left out. You have done everything. Just my thought was going that in case you plan such cases, so maybe
Yeah,
you can think of in ISR cases better
absolutely.
to use those modalities.
Yes.
Thank you so much for showing such a wonderful case.
Thank you.
So we move to the next case.
Congratulations, Dr. Isha. Can I have a word?
Yes, ma'am.
Yeah, please go ahead. I'm sorry. Yeah.
Yeah, I mean, for the fact that we are going to consider rotablation, it wouldn't be easy in this particular case because of the hinge point and the location between the mid and distal RCA. So
Yeah.
when your nodules are located in one of the curvatures, you're not sure where it's going to burr. So if you have an
Definitely.
option using an orbital, maybe yes, or an IVL, yes. But
Definitely.
I would be a little skeptical in using it in this particular case.
Yeah, of course, that's a questionable thing because you may get stuck in that rota. But orbital, and you are right. IVL could have been a better choice in that case.
One question that had the wire been behind the stent struts, then what would have been the strategy? Because OCT I took after dilating the lesion. There was nothing I had in my hand. So
in that scenario, I have once or twice tried a dual lumen catheter, Richa. And you just keep your catheter at the tip from where you're thinking it is going behind the strut, and the upper portion will guide you into the stent. So I've encountered this once or twice, and I could bail out through this strategy. I'm sure others must have encountered the situation. We can hear from other experts here. Yeah.
Can I just add one point?
Yeah.
I think, Richa, you already said that you're always maybe confusion of having under the struts. So what I said that you have to find the where you're under the strut. Again, OCT going over the under the strut, taking a pullback is not a very good strategy. So you point it out, take a dual lumen catheter, try to go inside. But I agree with Tripti ma'am's point also because there's a calcified nodule. How much you have been able to, because you need some ablation therapy in this case. Either the form of orbital, go for IVL, or maybe you can just go for your rota ablation because these will recur. Because and the specialist thing is the DEB. Since that we don't have a very good, data for the calcified nodules in DEB cases. So that was a tough case for decision, but the recurrence rate, which I think which will be very high in your case in this because there is a nodule, you have to ablate it, you have to expand it, and doing a DEB, I don't know how much strategy. So the only thing is if you're under the lumen, let the wire be there, take a dual lumen catheter, redirect the wire, and go inside it. Because and leaving the case will not cause any problem. You have created the dissection, patient, nothing will happen. You can come back again, maybe after a day or two, with a new strategy to ablate that nodule. What I feel.
Yeah.
Ma'am, may I?
Yeah, please, Ankush. Please. Yeah.
So these kind of cases at our center, we are doing we have got a laser. We have found that these kind of long ISRs and CTOs, recurrence rate is very high. So as rightly said by Dr. Richard, it's very important to identify the cause of ISR, number one. And number two, we always we have realized that debulking is very important in these cases. In our lab, we are doing one trial with the use of 25% contrast there for lasing these patients. And I'm not sure, we do believe that using debulking therapy, either in the form of rotablation or with the laser, may improve the outcome. But we have found that using both laser or arthrectomy, or maybe for that for that purpose, I will also, many a time the cause of ISR is underexpansion, and most of the time it's a poorly prepared bed, as Dr. Sujata said again and again and again, you have to prepare the bed. Okay. So we have found that all these three modalities, like arthrectomy, laser, and IVL, they actually prepare the bed behind the stent also, and to give a appropriately, and I'm not sure about that nodule, if I may say so. I think that was a part of, largely a new intimal hyperplasia. And it would have been great if we have taken, imaging after prepare, before, in my practice, we always see the preparation of bed if we're using imaging. Like if you're using angiographic guided, DEB implantation, that's something else. But if we're using imaging, maybe IVUS or OCT, we always look for that we have got a adequate dissection, adequate MSA, then only we go and place DEB. And we have seen that by doing so, we get an actual very good, positive remodeling in a long-term outcome.
Definitely. That's some nice tips and tricks from Dr. Ankush regarding lasing these lesions. And if anybody wants to comment further, or should we go ahead for the next case in the interest of time?
Yeah, we can go for the next case.
All right, ma'am. So next, I think Dr. Anpurna is presenting. Hi, Anpurna.
Yes. Hi,
yeah,
hi.
please. Yeah.
Yeah. Good evening, dear friends. Fantastic meeting and excellent cases. I would like to share my screen. Not able to share, I think. One sec. Yeah, can you see my screen, please?
Yeah. Make it in presentation mode.
Yeah, I'm doing that.
Yeah.
Yeah, sure. So good evening, dear friends, once again. So today I'm going to present a case, simple case, basically catch-22 scenario when you get true bifurcation in ACS. Yeah. So my patient was 59 years old male, known hypertensive diabetic, admitted with evolved interval MI, basically delayed presentation. 2D echo showed interval hypokinesia EF of 40%. Coronary angiogram showed mid-LAD bifurcation lesion. Critical bifurcation lesion, basically Medina 111, with distal thrombus in LAD as well as in diagonal. RCA showed mild plaque, and L6 also showed moderate disease in OM. His creat was normal, sugars were fairly well controlled. So usually this was the angiogram. You can see Medina 111. I just want to freeze it at some point. Yeah. You can see there's a large septal coming up, and LAD and diagonal fairly good sized vessels, but there's a lot of thrombus distally. So what should be our strategies? So basically, obviously, LAD stenting has to be done. There's no doubt what to do to the diagonal. Diagonal looked moderate side vessel to me. And the ideal would be, the ideal strategy in this case would have been stent LAD and do DEB to diagonal, obviously, because we know that we are going for more of provisional stenting than bifurcation nowadays due to extensive restenosis rates, high restenosis rates in these smaller vessels. But then this was a scheme case where they did not allow us to use DEB because the DEBs in our states are expensive. So I had no other option but to go for dedicated bifurcation stenting because 2 stents were allowed. Yeah. So this is how I decided to go ahead with LAD was first I dilated LAD because the IVUS catheter could not pass. So pre-dilated LAD, then did IVUS. This was a pre-PCI OCT analysis. You can see the distal LAD looked okay. And there was a, mid LAD onwards, there was a fibrofatty plaque. And at the critical lesion where the diagonal takeoff, there is a critical lesion and the MLA was close to 1.91. And there were some dissections caused by the pre-dilatation of the LAD. And there was a little bit of fibrocalcific lesion. The calcium was not significant. Because in fact, angiographically, it was not visible at all. So decided to go for upfront bifurcation strategy because patient was hemodynamically stable and gave intracoronary tirofiban for whatever worth after pre-dilating the LAD. And you can see there is a clearing of thrombus. There was slow flow in a diagonal, pre-dilated diagonal with 2.1 non-compliant balloon. And this was the result. You can see post pre-dilatation of LAD and diagonal. There was little thrombotic tax in mid LAD. Diagonal, you can see there's a reasonably big artery with a bigger supply, reasonably big supply. Then decided to go for mini crush because in bifurcation, whatever you are comfortable with the strategy, you should go ahead with that. I was comfortable with mini crush. So took 2.5 by 16 millimeter balloon in diagonal. The LAD lesion was pretty long. There was a longer plaque proximally and distally. So I had to take a longish stent of 3 by 40 millimeters sirolimus eluting stent. Deployed diagonal stent. Then removed the wire. And then deployed the LAD stent. Yeah, this is the deployment of the LAD stent at 12 atmospheres. Then did POT with 3.5 by 12 NC balloon at 16 atmospheres at the diagonal crushed diagonal stent. Then recross the diagonal with fielder FC wire because for recrossing fielders are really good or cross 200 usually, but luckily I could cross it with fielder FC wire. Then later on, after post dilatation of the LAD stent with 3.5 by 12 balloon, I performed simultaneous kissing balloon of LAD and diagonal both 2.5 by 15 and 275 by 15 serial dilatation. Then both the vessel dilatation made good carina and did report of proximal LAD with the 4 by 12 NC balloon. Here you can see the neocarina and few stents only struts were protruding into the LAD. So this was the final result. You can see good final apposition of the stent and you can see the diagonal stent also very well deployed as well as the LAD stent. Here you can see. So post-procedure OCT. You can see the distally there are no dissections. At the carina, you can see figure of 8, few struts protruding, but the 3-dimensional you can see not significant struts protruding into the ostium of the diagonal. Proximally again no dissections, good area achieved. So just take home message that it is possible to do upfront bifurcation in ACS when both vessels are large and Medina 111 when we don't have much options. And if the patient is obviously hemodynamically stable, bifurcation PCI should be obviously done with imaging for optimization of stent deployment and to look at the neocarina as it's associated with long-term better result in some terms of side branch, reduction in side branch ISR. We have already heard Dr. Ankush saying about the side branch ISR and the poorer outcome results if you don't do proper post-dilatation during the index procedure. Thank you.
Thank you, Dr. Annapurna. What time of the day you are performing this procedure? In the day, night? What?
Daytime.
Daytime. All right. So
yeah,
that is most important.
Yeah, that's very important. Yeah.
So nice case, nice result. But I have a couple of things which I want to discuss. One, this is ACS situation, and if you can get away by only putting LED stent and then just keep a wire there, and then see if you feel that, because I could see that there was no significant disease at the diagonal ostia. Is it? Did you?
Yeah, critical, because I did OCT. When we did OCT, diagonal was, there was a critical stenosis of diagonal. There's no doubt about it. Otherwise,
anyways, I think
provisional and come out, because all of us want to do quick in and quick out, and that's the end of the story in whenever we have thrombotic lesions. But here, the diagonal was pretty big. That's the reason.
And number two, while you are doing crush, there is no need to take out the side branch wire. I mean, some people keep it, some people don't keep it. It will actually give you an access that from where the side branch is going. And then so what it does, it gives you a reference, number one. So mini crush also, you can keep the wire. There's no harm in keeping the wire after you can just...
we were using aux wires because it was a steam case. And if you have an aux wire, you can jail it behind the stent when we do the pot. So that was my fear. If had it been, box wire, I would have probably kept it. And we have already seen people struggling with the jailed wires who have forgotten to do that. So that's the reason. And I thought I use this thin strut, stents. That was also important because we have seen that the largest struts, sometimes it's difficult to rewire it. My stents were 70 microns thicker. So thinner struts are always better, and the open cell design is always better to recross into the side branch. So these two things I took care and hoped and prayed that I crossed the, recross the diagonal. That's all.
So you took all the steps, you crossed it, you did pot, then crossed it, then did a kissing, and then final pot. So these are all steps to be followed. But if you keep a side branch wire, what I have seen in my case is it actually, and once you keep the side branch wire and then you cross the wire through the stent lumen and then you park a balloon, it is easier to push a balloon rather than you're pushing it on the wire which you have just taken out. So this is what is mentioned, and this is, if we follow, then sometimes we can just have an easy access of the balloon into the side branch. That's there if you are just trying to open the struts. Anybody wants to we have other panelists.
Anu, very nicely executed case. All the steps were fabulous. The only thing which I felt was for a mini crush, the diagonal stent kept in the main LED was little longer than what I would have.
Yeah,
it was like 3 or 4. It was like a conventional crush kind of, Anu.
Yeah. The thing is, I tried to keep, because the angle of the diagonal
70 degrees.
It was
not clear.
accurate. Because of that angle, so either I was in the diagonal or in the LED. So I could not keep, 3 struts. That's what we say, we should have only 3 struts in the, main branch. I tried my best. I believe me, I spent at least 5 to 7 5 minutes or more than that time, in this case to get it. Then I said, doesn't matter, 1 extra strut, it's okay. We will crush it with a bigger balloon. That was a technical difficulty because of the angle of the diagonal. The takeoff of the diagonal was such that either you were here or you were into the diagonal. You would have missed the ostium. That was my concern. So I didn't.
Very right. And secondly, the angle and the size was compatible even with culotte technique. But as you said, whatever makes you feel comfortable.
LED was bigger than diagonal. So
yes.
Usually when the diagonal and LED are same size, I would
see, the only advantage of tap and culotte is that if you wanted to do a provisional, you could kind of change it to tap or culotte later.
That's another advantage.
Rather than
the size discrepancy were diagonal and they were not of the same size. If they were of the same size, I would have used culotte. There's no doubt.
Right. And otherwise, you got a very good result and very good flow also. So that's fabulous.
But now 6 or 9 months follow-up patient is doing fine. So
good.
That's
I must congratulate Annapurna for doing such a lovely case. and getting the finest result. Because sometimes I have seen, like in acute coronary syndrome situations, I would leave the diagonal, just open it and just maybe do some FFR or just IVUS and see, leave it. But sometimes I see the later on patient gets chest pain, the diagonal gets occluded, then you are in trouble in midnight or sometimes. So what Annapurna you did was really correct. That you have made the diagonal to flow well and get a good carina and very nice OCT pictures and got the correct carinal position and the struts. So I think you saved that midnight crush again, going back to the lab and opening the diagonal. That could have been much worse. So thank you and congratulations.
Thank you. You are very right. I mean, all these years, many times, like maybe in initial years of practice, I was not, when we were not doing bifurcation, very frankly, I would just tend the LED and come out. But now, once you become, more well versed with the techniques and you want to get the best results for the long time, and my patients, I'll tell you, one or two patients have come back with diagonal pinching again, and I have done depth to those after maybe 3 or 4 years of time.
Yes.
And also, we have seen cases wherein you leave these diagonals, there is a thrombus there, and the thrombus propagates into the main vessel,
Yes.
and you get stent thrombosis in the middle of the night, diagonal not flowing, which was earlier flowing. So these are the catch-22 situations. That's what we say, that you do best whatever you can do at the time of index procedure to avoid the post-procedure complications and long-term, then the patient's coming back. So do whatever you do at that point of time. So because later
Exactly,
on
you
we
did
are
the
going to
case in a
repeat it.
daytime. That was very nice. Well done.
Thank you so much.
Nice. So
We go to the next case.
yeah, we move to next presenter.
Slightly here.
Gauri?
Because you're crushing, just in case,
Yes, Sridevi.
how would you have approached it?
Gauri and Sridevi.
I mean, would you have waited to recross and do it at a later time, or you would have stent there? If you take out the stent, it's difficult for you to go in with a main branch balloon to tackle things. So how would you deal with a distal dissection in the side branch with the mini crush technique of using a main branch stent?
Sorry, I didn't get you.
Ina, your voice is breaking.
Yeah, your voice
I
is
think
breaking.
little,
Initially, I could get only last part of it.
Could you repeat your question, Veena? We didn't follow actually. But...
Yeah, my question is slightly theoretical. When we are doing a mini crush technique, am I now clear?
Yes, better.
Okay. When we're doing this technique, when you're crushing the stent with a main branch stent, what if you have a distal dissection in the side branches? Would you deal with it at the second time of recrossing the
No.
At the first go, would you have chosen a balloon cross the stent and then take branch stent?
Whenever we are doing these, sideband deployment, we do it at a lower pressures so that you don't cause distal dissection in the side branch. First of all, go low pressures, come back, couple of struts, go into the main branch, inflate the stent at a higher pressures. So the distally, you see to it that you just deploy the stent and come back, and with the same balloon you come back and deploy. That's what normally I do. Come back a little bit and do, and then you deploy the main branch stent. So usually you try and avoid the dissection of the side branch, because then you have to go through the main again and deploy another stent over there. So usually you go low pressure. That is one key to reduce the side branch dissection. That's what.
Anu, may I add to what you just said, Veena? In mini crush steps, they always mention you remove the wire of the side branch after checking that there is no dissection distally.
Yes.
So when we are actually taking out the wire and balloon, first we check there is no distal dissection, then we take out the wire.
Always. That goes.
No, that's all right. But here what we have is a main branch stent. Just in case you have a dissection in the diagonal vessel also, how would you deal with it? Because
that's the reason we do
main branch stent to tackle the side branch issue.
No, I didn't get it. So that if when we do pre-dilatation of the diagonal originally, so if you dissect it, so you have to stent it. That's why you go with the upfront mini crush technique.
No, what she's asking is that let us suppose you have got a stent in a main branch and
Right.
you are deploying your side branch, stent. And after deployment of side branch stent, let us suppose that there is a distal edge dissection. Now, what will you do? Because you have got a stent in the main branch. So, answer to this question is you deploy your main branch stent and you do, you can do that because here the length of side branch stent that is protruding into the main branch is very important. That's a very important question. That is why, because of these complications, that revised crush, mini crush, nano crush, they came into existence. So that even if you have to take your device before without crushing, it is possible. I believe that was your question, madam.
Yes, very much. I think probably got it better than I.
Yeah, thank you.
We'll go
So
to
we
the
move
next
on to next case then. Yeah, in the interest of time. Yeah, please. The next presenter.
Mr. Gauri, Dr. Gauri. Gauri, are you ready?
Yes, madam.
Yeah, please go on.
Please start. Yeah.
So my case is I was guided PCI in left main system, madam, left main coronary, and it is like dominant left main left system. The RCA is very small, and I'm doing it in a setup like where I'm the only performer and single cardiologist setup, and we have so minimal uh, resources here. So the reason
Gauri, go to slideshow.
Yeah, madam, slideshow. Is it visible? No, madam.
No. Go down. Go to the slideshow, Gauri.
Okay. This is.
Ma'am, can you start the slideshow from the slide 1, ma'am?
Yeah, sir. Is it? It is.
Yeah.
Yes. Good to go.
This patient presented at a, this is from the STEMI program, madam. This patient presented with CHC with Andrew Wall MI, QRBB MI, and he was in shock. BP was not at all recordable. The local physician, she has called me at somewhere in the night, and the patient is 75-year-old, and he was his pulses and BP were not recordable, and ECG was showing QRBB. So I told her to thrombolize the case because there was no way that he can be brought to the center within time. So after thrombolysis, the patient stabilized, his pressures improved, and he was referred to us. And his hemodynamics were pretty good, and echo was 35% EF. So this is the ACG that the patient presented to us. So the next day we have done angiogram for this patient, and this shows that the LMCA is almost totally occluded and the thrombus or lesion is extending into the LAD. And seeing that LCX was also seems to be involved, and the system seems to be calcified. OM was also involved, and RCA was very small. So we can see that there is OM seems to be involved, and the ostium LMCA is disease from the ostium, and so the distal vessels, distal LCX and distal LAD, they seem to be good. RCA, when we see it, it is very small. So this is the RCA. Hardly there is any RCA in this patient. So the syntax score comes to around 33, and patient is post-MI, and we immediately ask the our first choice was CABG. So the surgeon said that it is very high risk case because the post thrombolysis Androval MI LV dysfunction is this patient is 75-year-old and these patient attenders were not willing for high risk procedure, and then we also told them to be referred to higher institute because even transportation is high risk. They were not willing. So what we did is we have reserved our decision based on the we felt we will take the decision after doing IVAS because we can find the lesion characteristics and we can decide based on that. So we have taken a 7 French JL catheter and guiding catheter. The opposite side, femoral side, was also prepared in case we need any IABP support. So we have wired the LCX and LAD, and we have dilated with 2 mm balloon. After dilating with the 2 mm balloon, I have sent the IVAS into the LAD. So after that, IVAS catheter was passed, and it shows that the lesion was just fibrocalcified. The calcium was not very thick as we have assumed from the plain angio, and it was superficial and thin. LCX also, seems to be mildly involved ostium. It was not very hugely involved, and the OM lesion was there. Next slide. So based on that, we can see that the distal LAD area and the ostial LAD is like this, and LCX is very good, and the LMCA ostium is very, very tightly stenosed. So we have decided that we will do some provisional stenting from the LMCA to LAD, from the ostial LMCA to LAD. And in case something happens in the LCX, we will convert it into mostly culotte stenting or TAP based on the hemodynamics and the emergency situation, because LCX is very important in this case because it is Androval MI and the patient is whatever LV that is functioning is solely dependent on LCX in this patient. So we have taken a 3x10 cutting balloon and dilated this in the LAD and the IVAS. So later the IVAS showed that the lesion was good, well prepared, and there were some cracks in the lesion. The calcium has yielded. So we were happy with this result, and then so we can see the cracks in the LAD. Just I'll show this. So the lesion was prepared well. So we felt we could straight away go for stenting. So even the diagonal was also very close to the lesion. Even that is also a concern for us in the beginning, because in case the diagonal might also close, the diagonal was also big. All these things were lot of doubts were there, because ours is a small center and something goes wrong, we might not be able to handle that case. So after we were able to confident that we might try in this case. So we can see that the calcium is pretty cracked, and the lesion has yielded. Calcium is also not much. So what we did is we have taken a 3x28 mm stent because the distal diameter is around 3 mm. So we have deployed the stent from the ostial LM to the LAD. So the ostial coverage was, we checked it in the elevocranial procedure. Ostial, this was, we have elevocranial, we have checked it in the eleutenyl osteal coverage, and then we have dilated it at 10 atmosphere. Post-dilated with 3 into 10 mm balloon at 14 atmosphere in the LAD and 16 atmosphere in the proximal LAD and 18 atmosphere in the LMCA. So later we have done with the pod balloon, we have done it 4 into 8 mm balloon in the LMCA osteum. So after that we checked it in the IVUS. I think the stenting PTCA. So there was good coverage in there was no malapposition in the LAD, and the stent has covered well. And LCX ostium, we have seen that the stent struts were protruding into hanging in the LCX ostium. So there is mild malapposition in the proximal LAD, but we have decided not to do it anything because it is at the ostium of the LCX. Later in the distal LMCA and LMCA, the stent struts were well opposed, and the result was also not optimal in the LMCA here. It was, I think, some malapposition was seen here, but then we did not want to go after it because the lesion was well prepared, well expanded. So the LMCA result was not optimal according to the IVUS. So we have dilated it with 4 into 15 mm balloon from the ostium, and we dilated it up to 10 atmosphere from the LMCA ostium to the pit. After this, we have removed the LCX wire, and then we have seen that the LCX ostium, the stent struts were hanging. LCS, then we have crossed it and opened it in with 3 into 10 mm balloon, NC balloon, and kissing was done. Again, report we have done with 4.5 into 10 mm balloon. So after this, we have got good post-stent diameter in the LAD, LMCA, proximal LAD, and LMCA, it was around 12 mm square, and osteoproximal LAD, it was around 9, and even distal LAD, it was around 8 mm square. So in our case, what I wanted to say or infer is that this patient might have been really very bad CABG case because his LV was severely LV dysfunction. Also, the patient was just MI case, thrombolized case, 75 years, lungs were bad. So without imaging, we would not have attempted this case, especially in our center. And even transportation risk was also there. So IVUS has helped us in detailing the lesion. Like, we could rule out the LCX ostium involvement. We could rule out much calcium presence. And also we could see that the lesion is also quite, we can deal with it with the cutting balloon. After that also, after cutting balloon also, we could see that the calcium has given away much, and we could stent it directly. So after stenting, we also needed to do it with larger pod balloon, and this was also seen. So recrossing was also required in this case. So what I wanted to say is, because of the IVUS, I could do this high risk case where the RCA support was not there, and the patient was literally depending on the LCX territory, where we could take this high risk case. PTCA videos.
Thank you, Dr. Gauri, for sharing your case, and this is commendable that you took this case, left main case, And I would say imaging gives you the confidence of doing these cases. When you see the results which are optimal, you can have a good night's sleep and you're not scared that in the midnight patient will have some stent thrombosis or some slow flow or reflow. So because you are seeing it, you are fixing it, you are taking help of imaging. And I think in interest of time, ma'am, Sujata, should we move to the next case? Yeah.
Congratulations in doing a low resource setting.
Yeah.
Congratulations, Dr. Gauri. You're really savior.
So this is like, very, even for me also, like, I had to take up this case because I did not have any other alternative, because surgeon was saying it is high risk case. Attenders were not willing for the risk taking. So I told them that I will take the decision after doing the IVUS only, because I can find the lesion characteristics and go ahead of only after IVUS. I told them IVUS here is diagnostic. I'm not going to take the case before doing the IVUS. So they have agreed for that. I just wanted to ask the question that if it were a thick calcium, like some calcium that might require the calcium modification, what would have been the best this decision that we can take in this patient? Because
Dr. Ankush, yeah,
to remove the side wire and some dissection happens in the LCX, we might lose the patient on table. So I just wanted to know in what way could we modify calcium in this case apart from the cutting balloon. So IVL, because if the calcium is high, we may not be able to cross it, or also this is LMCA, we may not be able to dilate it for longer. So I thought I just wanted to ask the panelists and seniors how we might deal with calcium in this case. This is the PTCA videos that we have done.
Yeah. In the meantime, Dr. Ankush,
So, Dr. Gauri, I heartiest congratulations for such a difficult case, that too in ACS scenario. And let me assure you, patient was not dependable on L6. He was depending on you actually, he or she, whatever. Number one. Number two, in this case, first thing, patient was ACS, anterior wall MI, left dominant, left left main disease. And I was sure that there was calcium. If you see, I was, slightly in a deeper way, the patient had a calcium nodule. So if we go by pathology, the calcium nodule causing ACS is around 5 to 10%, and that too eruptive calcified nodule. So if you are having a calcified artery, and imaging showing you eccentric calcium that was there in this case, and you rest assured likely it will be eruptive nodule, and these eruptive nodules are usually very easily modifiable with the even with the non-compliant balloon, with the cutting balloon. That is why after your cutting balloon they were easily modifiable. Number one. Number two, the only problem with the eruptive nodules, they come back even inside the stent, but that's not a problem. But here the most important thing was that imaging showed that it was calcified lesion. You used cutting balloon, you knew that your LCX ostium was okay, that you can go for a provision strategy. So, and in this kind of scenario, let us suppose you have a heavy calcium and you need to modify that. The safest bet would be put a IABP, take 2 wires, use IVL if required, because IVL you have got a option of putting 2 workhorse wire, and you can work anytime on that. That is my personal favorite modality in case of bifurcation lesions. In those cases, we don't go for 10 cycles in a single go. We give 5 cycles, 5 pulses per cycle.
So one more thing we can discuss about this case is ideally you should do these cases on mechanical support, because something goes wrong. You just do a right heart cath, see pressures, because it's the LV dysfunction, ACS, left main scenario, left dominant system. So if something goes wrong, your patient might crash on table. So kudos, you could bail out your patient without having any kind of support, but ideally, if available, we should think of mechanical support in these kind of cases.
I had femoral artery punctured, madam, in case we can put an IABP as early as possible. But then, yes, I had that opposite femoral artery punctured, so that but it was not required. Touch wood, thank you. So see, this could have been like, for me, even before we make a hard team discussion, I think sometimes we might IVAS might even help us even before taking decision in this case, because RCA was hardly present. This LCX was very important for this patient. That is the only thing that was concerning me. So if some dissection happens in the LCX, then I wanted to change it into the load technique, because LCX was even bigger than the LAD in this patient.
Yeah. Thank you. Thank you for presenting this case. And now we next move to the next presenter, Dr. Lipi. Is she there? Dr. Sridevi?
Devi. Dr. Sridevi Lipi is not.
Yeah.
Yeah, we stick to time. We have two more presentations, Dr. Sridevi and Dr.
Good evening, everyone.
6 minutes each, and then 2 minutes of discussion. Yeah.
Mine will be simple case.
Please share your slides.
Are you able to see my slides?
No, not so far. No.
1 minute. I'm just sharing.
Sridevi and Gauri were the first ones to submit the cases. They need a round of applause.
Yeah, 1 minute. I'm trying to share the screen.
So, I'm happy with Gauri, She's in a small setup in Kadapa. She's getting inspired with Wincars, all of you young cardiologists, and she's trying to.
Sujata, are you able to see my slides now?
No, Sridevi. Just check again. Don't get tense. Be cool.
Yeah. 1 minute. I'll just try to share. I'm not able to see the share.
Kiran, help her, no?
Yeah. Ma'am, can you see the share screen option, ma'am? In the
1
bottom.
minute. Bottom.
Yeah. Now your screen has been shared, ma'am.
Yeah.
Oh. Can you put it in the slideshow mode, ma'am?
Yeah. Are you able to see now?
No,
yes,
ma'am.
Devi, go ahead.
Able to see?
We can see the PPT, ma'am, but it's not in the slideshow mode.
Not in the slideshow.
Yeah, from beginning.
Perfect.
Yeah, good evening, everyone. I thank Wincars for giving me this opportunity to present my case. It is not very complicated case. A 58-year-old female patient was presented with complaints of chest pain and dyspnea of 2 days duration, and she had history of angioplasty and stenting to LCX and RCA done 8 months back for the history of inferior wall MI. At the time of examination, patient was hemodynamically stable and systemic examination was normal, and her ECG showed QS pattern in L23 AVF with T inversions in inferior leads, and echo showed a regional wall motion abnormality in inferior and lateral walls with mild MR, and her troponin was positive. And this is angiography. We did angiography. Left main coronary artery was normal, LAD was normal. LCX showed grade 4 instant restenosis with distal TIMI2 flow. RCA, there was grade 3 instant restenosis in mid RCA. So this is left coronary shoot. LAD was grossly normal. LCX, there was a grade 4 instant restenosis with distal TIMI2 flow. And this is the RCA, instant restenosis grade 3 with extending beyond the stent margins. So we decided to do OCT guided PTCA for this patient, and we through femoral route we approached. Left main coronary artery was engaged with 6 French EBU guiding catheter, and we tried to cross with the workhorse wire, which we could not, and we used Gaia 2 wire to cross the LCX lesion, and then we pre-dilated with 1.28 balloon and 2.5 15 balloon. after crossing with Gaya wire, we exchanged with workhorse wire with the help of the microcatheter. And this was like redilatation of the LCX lesion. And then we took a OCT run of the left circumflex artery. So this is the OCT run. I'm running it from proximal to the distal. So this is the left main, which was normal. LCX, proximal LCX, there was a disease with neointimal. This is a combination of the neointimal hyperplasia and neoatherosclerosis. But there was stent expansion was good. There were no mechanical factors responsible for the restenosis. And this restenosis is extending beyond the stent margin. There were no calcific nodules. And so mechanical factors were ruled out. So after the OCT run, we pre-dilated the lesion with 2.515 NC balloon. So after pre-dilatation of the stented segment, we stented distal LCX with Yukon choice 2.75 32 balloon with nominal pressure, and proximal LCX also we stented. This is the distal segment we used 2.75 32 Yukon choice sirolimus eluting stent, and proximal LCX is stented with 336 balloon, 36 stent Yukon choice. So this is the proximal segment. We placed the proximal stent into the ostium of the LCX. So after stenting, we post-dilated both the stents with 312 NC balloon. So this is after stenting, we took a OCT run. So this is again from proximal to distal. We found some areas of under expansion even with after post dilatation. But there were no areas of dissection. So after this OCT run, we again post-dilated both the mid and the proximal LCX segments with 312 NC balloon. And after this, we did not do any OCT run, but we took a final shoot, which was good. Dimitri flow was established. So next we did PTC and stenting to the RCA. We engaged right coronary with JR 3.56 French guiding catheter. We could pass the regular run-through wire. We dilated RCA segment with 1.5 15 balloon. And after pre-dilatation, we took OCT run of the RCA. This is the run of OCT run of the RCA. So proximal RCA is normal. Above the stented segment, there is some lesion is starting, and we felt it is a combination of the neoatherosclerosis and neointimal hyperplasia. There were no areas of calcium nodules or calcification. There were some areas of microvessels within the plaque, but overall we felt stent expansion was good. There were no other mechanical factors responsible for the restenosis like stent fracture. And beyond the stented portion also there was instant risk. This is the stented portion, but after the stented segment also there was some disease in the distal RCA. So after OCT run, we pre-dilated the lesion with 3.5 20 NC balloon, and then we stented distal RCA with 324 Yukon choice sirolimus eluting stent. This is the distal RCA, and then we stented proximal RCA with 440 Yukon choice sirolimus eluting stent, and after stenting, and we post-dilated a distal stent with 3.5 15 NC balloon, and proximal RCA we dilated with 412 NC balloon. This is the OCT run after stenting. There was some areas of stent under expansion. So after OCT run, we again post-dilated distal RCA and mid RCA also. This is the distal RCA. But this is the final result. After the post-dilatation, we did not do any OCT run. Final result, we felt it is good. So this is final result of both the LCX and RCA. This is the final result. So this is the definition of the instant risk process. Probably Rita is discussed already. So this is the angiographic classification.
This was discussed with Dr.
Yeah, this is already discussed. So I will go into details.
Yeah. So in the interest of time, So
I'll just
Dr. Sridevi, we could see a case, nice expansion of the stents. The only thing we know that if we have to use these long metal layers, it is always better if we can bail out with DCB. That is always a better situation. But we all have to keep in mind that we are working in a scenario where the DCBs patient cannot afford, or these are not approved for the patient. So most of the time, this is to take that we have to put long DES in ISRs. Do a double metal layer. This has own problem, even if you give best of results. So my only take on from your case is this. Otherwise, you have expanded through OCT, you have taken all the decisions rightly, and you have put stents and you have well expanded these. Can we move to next case in interest of time? We will
Yeah, thank you.
take questions after that. Thank you, Dr. Sridevi. Nice case, huh? So Dr. Lipi, is she there? Yeah.
No, Dr. Lippy is not there. It's going to be Dr. Tripti.
Okay. So Tripti ma'am, your presentation, Refining PCI, the role of physiology and imaging.
Yeah.
Thank you, Sridevi.
Yeah.
Okay.
Thank you, Sridevi.
Yeah.
Very well done case. Yeah. Gautam? Gautam? The full screen.
Ma'am, go to slideshow, please.
Slideshow.
From the first slide.
Yeah.
Ma'am, can we keep it short?
Yes. This is actually, thank you, Dr. Sujata, and thank you, Wincars, for giving this opportunity. Actually, I was making all the slides for the PG presentation, actually, because there is a present scenario and the future direction of the precision of the refining the PCI, the role of physiology and intracoronary imaging, the use of precision microcatheter, and which can be used in the future. Of course, we are still looking for all these new gadgets which we can use for the future direction of the treatment for this precision of the PCI. So as per the guidelines from the ACCHA 2021, the recommendations for the use of coronary physiology has been given 1A indication for the intermediate lesions for FFRs and BR13 where the benefit of the FFR is better than the doing the cases. And I will just show you the slides where we can see that when we use physiology, how the benefit passes on to the long-term benefit that we all know by the multi-center trials, and recommendations for use of intravascular ultrasound and OCT and the imaging techniques. They have 2A and decision should be taken by all the scenarios. Nowadays, it is unanimously taken as a positive sign to do the imaging as well as the physiology for each and every case. These learning objectives are to understand the role of physiology in intracoronary imaging and PCI for the decision making, to explore the use of pressure microcatheter. Of course, we don't have pressure microcatheters yet, but in future we are going to get it where we don't have to use the recurrence of the wire, putting the FFR wires repeatedly. So this will optimize the situation much earlier, and this will be AI based. So I'll show some pictures for this. So this is how we can improve the accuracy, reduce the complexity, and predicting the efficacy and optimizing the durability. So this is what comes through all these techniques, which we are going to use in future, and presently also we are using. So how to increase the accuracy? Like in such borderline cases where there is intermediate doubtful cases, how the FFR and the microcatheters would reduce the complexity and make a better position for the future. Like if we do the syntax score for such lesions, the mostly it will be more of a medium or the high syntax. But when we use the physiology, the syntax score comes down, and the low syntax will give us a lesser amount of functional syntax score, will improve the outcome of the future positioning of the stents, etc., where we can reduce the number of use of the stents by using these technologies, and less number of stents will be used, and for the fewer stents inserted, lower number of complex lesions will be treated, and the patient will have a better optimizing durability of the future prediction of the results. And now the pullback FFR has come, where we have a single point FFR and the pullback. In the pullback, we have different sizes. Like single point, we can use FFR pre and post. And when there is a long stent, long lesions, diffuse, then how to optimize these long lesions? By putting long stents, we can use them, but residual angina will be more in these cases as compared to doing only the focal stenting and reducing the long stenting and getting the better outcome in the future. And residual angina will be less in these cases. So these are all studied. This is the microcatheter on the pressure wire, and the pressure microcatheter should be used on the routine wires. There's no pressure wire required, and this is AI based, and this is going to happen in the future. And this will have the optical pressure sensor and one mark, and piezoelectric resistance pressure markers, two markers. And this will give us a, now there is some studies are going on. Insight Life Tech True, they are going to give us like this smooth pressure microcatheters are coming up, and where we will have this kind of future, like we can do with microcatheter CRR, IFR, DFR, DPR on the one wire only, and no need to change the wires frequently. So these are all going to optimize our future serial, because of the pullback will be fast. So with this FFR pullback and the AI generated, there are some new techniques are going on. And this hypothesis 1 and 2 will improve the concerning target vessel failure and the repositioning of the newer, if this nowadays more and more we are using drug coated balloons rather than the stents for long lesions, even for the left mains also. The now future direction of the treatment of basically PCI will be stentless PCI. That is our focus in the future, so that it will be metal free PCI. And how to do very precision in the metal free PCI, where 70% will be metal free and only 20% will have some stents, and rest of it will be having the I think the BSR. So this is going to happen with these kind of AI based techniques which we can use for the future optimization, physiology guided. And trends for the future IVUS, like what we have now presently, now the high density, high intensity IVUS techniques, where there is 74% strategies of the patient will be taken up by the high density IVUS, and which can improve the image quality and give us a better pullback distance. And this will also be AI generated. So this IVUS will be better than the OCT also, and less contrast, and we will have better outcomes. So these are all in the future, how the present plaque rupture shows with the branch vessel. You can see in the 60 megahertz high resolution IVUS, which is coming. And this will be having better pull, means 60 size frames will come in each pullback, and 5 millimeter per second will be the pullback, so that it can be fast generating pullback for the IVUS, which will give us a better result and better contemporary outcomes for this, more display. And this is what is the example of that IVUS pullback for the auto-generated segment automatically. It will give the complete resolution as well as co-registration in the real time. And then of course, as we say, the contrast-free images will be much better, as Dr. Rupali had shown us. So this will be our workflow and learning for the future. So these are all future generations which are being now studied in the EuroPCR. They have shown all this. So what are our key takeaways in the future? Pressure microcatheter facilitates the implementation of contemporary physiology, and high resolution IVUS will give us AI enhanced automated lesion assessment, and the appropriate and recent implementation of both tools makes PCI more controlled, warranting an optimal final procedural result, and that will be stent free. This was an interesting case. Actually, she was referred from the other center after the angiogram, where there was a borderline, or you can say little tight lesion at the ostium of the LAD. So they wanted to ask whether we should go ahead with the osteal LAD stenting or not. So where we did the physiology based in this case, and we found out that after putting the this one OCT, we did the OCT pullback, and we saw the proximal LAD, as compared to the distal LAD, the proximal osteal LAD, there was not much of difference. The total amount of the area was almost 3 to 4 millimeter square, and the lesion was only 40 to 50%. So we did the after the OCT, we did the FFR with our routine FFR. First optimization of the FFR, and then the first with the nitroglycerin, and then with the hyperemic, like after adenosine. So it was negative. That's why this patient was not stented in the ostium of the LAD, and she is under follow-up. So these kind of cases where there is in between intermediate or little bit more than intermediate lesion, but we find out the clinical scenarios, and we see where the stent could be optimized, or we should not stent such lesions, and we should do the optimal medical management, which is nowadays very good actually. So this will be our future image based, complete image based, and the angiographic co-registration. There is no wire, no microcatheter, nothing, just a fluid dynamic equation. So this could be our future. And then this VFFR, we call it, that angiographic and the virtual FFR. So this has some do's and don'ts and some directions to follow. And these are some of the examples of angiographic follow-up of the FFR, which can computerized and AI generated, which can give us a much better results in the future. So lot of learning, lot of new things, stentless angioplasty, and these things are coming up in a big way now, faster, and we have to learn all these new technologies. Thank you so much for giving this opportunity, and I am really thankful to Sujata ma'am and all the Interventional Cardiology Forum because it's expanding so fast that it is very difficult to keep up pace with all these new technologies. Thank you so
Thank you,
much.
ma'am. Thank you for the crisp presentation. And over to you, Dr. Sujata. I think we are running actually late. It's 9:30.
I think we went half hour late, not more. So I am very thankful to all of you for coming to this monthly session and taking part so actively in it. First, I should thank Dr. Ankush Gupta for presenting original work, Rupali, the whole entire team. I thank all the chairpersons and the technical support team. And Tripti ma'am, thank you for the glimpse into the future.
Thank you.
Okay, bye-bye. Good night.
Thank you all,
Good night.
guys, again. Bye.
We really thoroughly enjoyed. Thank you.